All right, welcome to week 5, video 13. This is the second video on race and pain management. In the first video, I introduced some basic ideas about how to read scientific articles, and then I sent you off to read a few and do an exercise about one, and now I just want to regroup and just see what we learned from that. So there's a lot of research on race and pain management, and it all points the same basic direction. Black people are less likely to get pain medication than whites. The difference is just in figuring out why this discrepancy occurs, how this happens, and what can be done about it. So, but the basic fact that there is a racial disparity, and that's due to some kind of racism, is well established. So, I had you look at 3 papers. One looked at pain assessment and recommendations and false beliefs, and that's the one that you did an exercise on. Another looked at appendicitis in children in emergency rooms and how often they were given pain meds. And another one looked at long bone fractures, arms and legs, broken arms, broken legs, to see how pain was treated there. And just to review, we're using what we call the semantic view of theories. And on this view of theories, the idea of a model is central. A theory is essentially a collection of models and hypotheses that relate them to the world. And models are basically like maps. They're representations of the world, but they simplify. And so your hypotheses that connect the map to the world is essentially just saying, look, if we use this map, we will be able to get around this territory fairly well, even though the map simplifies by, for instance, ignoring elevation. So when we are attempting to determine if one thing is caused by another, for instance, if false beliefs about race cause a difference in pain management, what we really want to do is have what they call a randomized controlled experiment. And in a randomized controlled experiment, you select people randomly from a population. That's one level of randomization. And then you randomly sort them into 2 groups, one of which has the potential cause and one of which does not. Often, though, randomized controlled trials are not possible. So we get prospective observational studies and retrospective observational studies. A prospective observational study finds a group that already has the cause, has already been exposed to the cause, and compares it to a group that has not. So the Tuskegee syphilis study was a prospective observational study because they were looking at people who already had syphilis. And again, it violated basic rules of consent and ethics because people didn't know what was happening and because there was not clinical equipoise. Okay, a retrospective observational study is a study that identifies a group of people in the past that have been exposed to a cause and observe what effects have already happened to them. And so the two of the pain studies we were looking at here fall under this category because they're just looking at medical records, right? So it's backwards looking. In that sense, it is these are less reliable than genuine controlled experimental studies. Another thing I wanted you to be sure to understand is the difference between the intended population, the sampled population, and the sample. The intended population is the group of people that we actually want to know about. For instance, in a political survey, you may want to know about potential voters. The sampled population is the population you draw the sample from, and this might be different than the group that you want to know about. For instance, if you want to do a survey on political attitudes, you might stand around a shopping mall, back when those were open, and interview people as they go by. Your intended population might be the entirety of the United States, but your sampled population is just people who go to shopping malls. And then the sample itself is the small number of individuals you actually talk to. An important distinction here is, an important thing to note here is the sampling method, right? How it is that you get the sample. And we made this distinction between a genuinely random sample, which is technically defined as a sample in which each member of the population has an equal chance of being in the sample, and what we call a self-selected sample, where people actually volunteer to be in the sample, or a sample of convenience, where you're just looking at the people who happen to be accessible to the researcher. And so here I asked you to identify different aspects of the studies we were looking at in order to get a sense of how they worked. So, for instance, Todd et al. Was the study of long bone fractures. They wanted to make an inference about American patients and doctors in general. So that's the intended population. And in fact, they'd previously done a study with Hispanics. The studied population is just emergency room patients and doctors in a particular hospital in Atlanta, Georgia. So the sampling method here is convenience. That is, the doctors were not randomly selecting people from across the country. They were just looking at an emergency room that was available to them. And what's relevant for us is that they were attempting to correlate two variables: patient race, and then whether pain relief was given and what kind. And I also note here that pain was noted in the patient record, and this is important for their understanding of how the discrepancy in pain treatment arises. So they imagine, or they lay out this chain going from the pain stimulus, in this case a broken bone, down to treatment. And in the population they sampled, or rather in their sample of the population, the stimulus and the expression and the assessment were all roughly the same, right? And the only discrepancy came up when the doctor made a decision to treat the patient. So that says something about where they think the difference, the split in the way blacks and whites are treated in emergency rooms arises. So this is actually from the other empirical retrospective study that we did on children with appendicitis and pain relief. That one broke apart moderate pain and severe pain, and it found a discrepancy in each of them. And then it also broke apart whether any pain relief was used or whether specifically opioids were used. And one of the things that you see here is that it looks like you see two kinds of effects going on. So black children are less likely to receive pain relief at all for moderate pain. And then when it comes to severe pain, they're less likely to receive opioids, but they're actually more likely to receive other sorts of pain relief. This might suggest that doctors are worried about opioid abuse and are concerned, more concerned about African Americans and opioid abuse than they are whites and opioid abuse, even though that's not the actual pattern of drug usage, right? Whites abuse opioids more than African Americans. All right, so now I want to look at the populations in Hoffman et al., which is the thing that I had you do an exercise on. The intended population here, as before, was practicing physicians treating actual patients all over America. But in this case, the studied population was different. Rather than looking at practicing physicians, they did one study on med school students, just students who aren't doctors yet, and one study on medical residents. And the sample itself consisted of 418 individuals. And again, this was a sample of convenience rather than a random sample. Hoffman et al. Have a different model for how this discrepancy in pain treatment arises. According to their hypothesis, the root is actually false beliefs about biology and race. And this leads to an inaccurate estimate of the pain of others, which in turn leads to unequal pain treatment. Now, this hypothesis is actually compatible with a hypothesis in Todd, because it could be that there are multiple ways, in fact, it's almost certain, that there are multiple ways that black people are being discriminated against in emergency rooms. So it may be that there is an unequal estimation of pain, and then even on top of that, even when pain is estimated to be the same, there is still unequal treatment. But we don't know the relevant effects of these two, the relevant size of these two causal chains, right? Actually, let me skip ahead a little bit and look at the false beliefs, because this is important. The items in boldface here are false. And what they say, these are all things like blacks' nerve endings are less sensitive than whites. Black people's blood coagulates more quickly than whites. Whites have larger brains than blacks. And the infamous black's skin is thicker than whites. All of these are false ideas that go back to the slave era. I talked about that in an earlier video where 19th century doctors, desperate to justify slavery, came up with all sorts of nonsense ideas about differences between black people and white people, and often engaged in cruel experimentation in an attempt to prove these ideas. But what we see here is that these false beliefs are still quite common amongst med students and residents, which is somewhat alarming. So the variables measured in this one become more complicated. What they do is they put together, what Hoffman et al. Put together what they call a false belief composite score. A combined score on a survey assessing the truth of 11 items, and this then gets simplified down to two values: low false belief and high false belief. And then this is then compared with pain assessment and suggested treatment, as well as the target race. The target race, we should note, is signaled by a ethnically stereotypical first name, right? So this is something similar that you see, for instance, when you look at studies of hiring or renting, right? You send out two identical resumes and you have the name Tyrone on one and Steve on the other, and you find that fewer people offer the guy with the stereotypical African-American name a job. So something similar is going on here. And this again gets, so these are given, these people have been given mock case studies. And race is just being signaled by the name of the patient. This is important again because it signals a difference between the sampled population and the intended population. We're looking not at the people's behavior in the real world, but we're not looking at real doctors' behavior with real patients. We're looking at medical students' behavior with hypothetical situations. And so it's always important to bear in mind that distance. In any case, we wind up with 4 variables here, and each of them get reduced to 2 values. So you have high false belief and low false belief. You have 2 values for race, even though we all know that race is more complicated than that, black and white. We have 2 values for suggested treatment, accurate and inaccurate. And all of that is used to suggest this causal model. False beliefs about race lead to inaccurate estimations of the pain of others, which leads to unequal pain treatment. So again, there are 2 separate kinds of lessons I want you to learn here. One is getting used to analyzing scientific articles, and the other is trying to understand this very real part of medical racism, this discrepancy in pain treatment. Okay, thank you.